Really apologize for your time. I'm gonna move forward, and I will get it done. I know anyone that some of you that are on that know me is a it's there's usually a bet. There's an over under on whether or not I'll finish in time. But so this one's going to be tough. But I'm going to do it, and we're going to be fine. We'll probably redo this again just because we did lose some people, unfortunately. But for the sake of the folks that are on there, I want to make sure that we are cognizant of your time, and in fact, we appreciate that. So I'm going to get right into sharing my screen, and whilst I do that, I will chit chat and introduce myself. While I'm talking, I cannot see the questions, so I will have a colleague look at those, but I will look at them after. So if any of my colleagues have issues, then let me know through Teams on text or something like that. Anywho, so my name is Chris Prue, and I'm getting pinged by one of my other colleagues right now too. And I am the director of education for Digit Soul, and I'm also in private practice and as a clinician. I've been a performance coach for almost 30 years now, and been part of the NSCA for just as long. And my master's and PhD work are in exercise science and biomechanics and performance-based outcome measures. So I do love me some data. I'm also have a doctorate in chiropractic, and I'm a practicing chiropractor. Was an athletic trainer for 15 years as well. So what we want to talk about today is combining, the use of digital analytics in looking at assessment and management. So this is actually part of a larger series that we're that we're calling "Everything is Better with Data" series. And so this one is entitled "Combining Digital Locomotion Analysis and Low Back Pain Assessment and Management." So what we did was we chose a specific topic for each one of these as we move forward, and we'll have a different one for each time. So be on the lookout for next month. We have one on the foot. So we'll be looking at really just kind of teasing out a couple different pathological conditions that we'll take into consideration. And so this one is low back pain. The next one's going to be on the foot, looking at neuropathy and plantar fasciitis specifically. So just a introduction, couple of key points, because we don't have a lot of time here, but two things really is don't be afraid of data, and low back pain is not pain. And hopefully I'll come across and be able to identify what exactly it is I'm talking about with that. And the data issue. I mean, we are so inundated with the amount of data that's available to us. And to quote a colleague of mine, I was on a statistics committee at the university, and there's a subcommittee for reaccreditation. And as you can imagine, it's about statistics and collecting data. And so as people like spitting out, oh, we should collect this, we should do this, we should do this. And the head of that committee was actually the professor of mathematics and statistics. And as much as I thought it was funny, because as much as he likes data, he says, whoa, guys, listen, there's no reason to collect information if you're not going to do anything with it. And that's an interesting, concept today. And this was it was a few years ago, but it really holds true today because we have so much information at our fingertips. So we really need to be able to decipher it. And that's kind of what I'm getting at is don't be afraid of it, adopt it and figure out how to implement it. And that's kind of what we're going to talk about. I always have a quote, and this has been my quote for the last 6 months or so. And one of the things I've learned is the best way to learn about something is to talk about it. When I'm lecturing, I'm thinking, because there's lots of things for sure that I don't know to be the case, and that comes from a person much, much smarter than me. And the reason I think that's important is to keep an open mind, and that, we're constantly learning. And especially as we look at data, even in research, the statistical power and the analysis that we're utilizing today is so much different than, when I started doing this 25 plus years ago. And the ability to tease out, relationships and figure out, what this data actually means. So, description of the course, we're looking at the effects of low back pain, and we want to cover a little bit of the current landscape. I want to talk about locomotion. I won't spend a lot of time on that, but it's important because then you need to look at the aspects that actually make sense and why we're actually doing this, and then the interpretation and some use case data, and then I think a simple conclusion, but sort of outlining what exactly it is that we're trying to propose here. And what's interesting too is, like, this is not really the overall commonplace, despite the fact that we are in a very, and I call it digital, but it's an innovative technology age of having information. So I would even call it information. Digital 0 and 1s. We've been doing that for decades and decades, but it's the type and the ability to collect the information that we're doing today. So we're trying to tease this down, and despite where we are today, there's just not a lot actually being used to inform our clinical decision making process. And I'll give you a little teaser. That teaser is, I estimate that within maybe 5 more years or so of this, and utilizing the technology that we have available at our fingertips, is we're probably going to be able to hopefully eliminate this classification referred to as nonspecific low back pain, meaning that nonspecific is we don't know exactly why people have it, but it's a bit of a problem. So how are we going to be able to do that? It comes down to human movement analysis and all the components associated with that. Now, I put in here like the techie stuff or the lab stuff. There's even more to it than that. So obviously biomechanics, watching someone move, using data, to collect that, but really kind of looking at, well, how do we use that information? What does it do for us? Can we get more than what we used to? And I'll show you a use case example of what I used to do in the past, which even today is stuff that people aren't really doing because, well, I used to work in a lab, so I was a professor, for 15 years, and so I had access to that kind of stuff. But that's not consistent with what we're doing in our actual, clinical opportunities here for most of what's going on in the outpatient setting for people working in the physical medicine and rehabilitation space, especially like chiropractors, athletic trainers, and physical therapists. So what we're going to be talking about here is specifically utilizing locomotion. So it's really moving from, point A to point B, from one place to the next under, one's own mechanisms or power, force, velocity, vectors, all the things associated with going through friction and moving across space. And so in humans, that's actually, propelling the body from point A to point B, which a lot of people, kind of use the term gait. And the term gait it's still very popular today. I look at it as being a little bit antiquated in terms of what we're able to accomplish with the amount of information, because a lot of people think the term gait is specific to, looking at the vectors and the physics of locomotion that are very detailed, and they think of a lab and they think of a lot of, equipment and a lot of time and things like that. So, and as they should, because initially, it was brought into our clinical world really because of cerebral palsy and pediatrics, right? But what's interesting is that even still today is really kind of held to being in a laboratory opportunity. It's moved a little bit into the outpatient, centers, and there are some pieces of equipment that again give us that sort of, as we refer to as a linear aspect of data. And now we have what's referred to as artificial intelligence and machine learning that feeds the system and makes it a little bit easier and timelier for us to be able to collect that information. So we're using locomotion or walking, running, jumping, other sort of movement patterns, and not just looking at, the definition of what used to be termed gait. Why are we doing that? So walking, one is it's something that, we all really learn how to do. And even if we've had certain injuries, loss of body parts and functions, we attempt to adapt to that as best as we can. Why? Because it has a certain level of independence to us as we make our way through the life cycle. We use it to evaluate functionality and mobility throughout the life cycle. And it has a lot of components to it that really bring the multi-system aspect of the human body together. So biomechanically and mechanically, I think that's what everyone really thinks of when we look at walking, locomotion, or gait analysis, which is the anatomy and the forces and the movement patterns. But keep in mind, even if you just go one level higher, the aspect of bringing in that neurological system, which incorporates the reflexes, as well as the voluntary aspects of moving from point A to point B. And then we can even bring in some other levels. So we use walking to evaluate the cardiorespiratory system, specifically in cardiovascular dynamics, such as aerobic capacity. Initially, that was used for vascular deficiencies, but now we actually use it as an overall assessment in cardiorespiratory. We use it for risk of fall. We use it to evaluate the effects of cognitive function or cognitive dysfunction. So why the reflex? And so when I first got into it, the purpose of that was because it was a really deep dive into the neurological system, not just like banging away on someone's knee and looking at deep tendon reflexes, but looking at the body as an overall movement pattern. So if we think back to the infantile stages where they learn how to crawl before they actually stand up and then eventually walk, is they're developing that cross crawl pattern, and it's innate. So it's ingrained in us as a natural, not just like a deep tendon reflex, but a reflexive activity that we don't actually have to think about. It still is involving the higher centers of the neurological system, which again is really cool because imagine being able to look at that influence from something as simple as just looking at walking. And it's really again just kind of evaluating a lot of the metrics that we've talked about with gait. Now, I think another thing that's interesting, unlike blood pressure, heart rate, temperature, 98.6 degrees, there's a lot of variability in walking, even when we look at the normative values. And that, my friends, was one of the reasons for the biggest challenges and why it was difficult for a lot of people to sort of incorporate this. Now, if I'm talking to clinicians or people that were in exercise science and biomechanics, then yeah, I mean, you learned it in school, and then some people maybe never have saw this level of equipment again because it wasn't accessible until recent advances in technology today, where now we can not only look at normal variations, but we can look at the pathological variations, and we can look at the variations associated with certain conditions that many of us may be treating. And then we can take that a step further. So, artificial intelligence in healthcare is making its way leaps and bounds, and it's moving very, very rapidly. Why is that? Well, we have a certain need. Our healthcare system here in the United States is such that a lot of people are overwhelmed, and the implications to having more efficiency in clinical care, but also better. And what I mean by that, so for example, the implementation of artificial intelligence in imaging studies, such as mammograms, has improved the diagnosis of breast cancer by 11%, which is really quite significant. And so the artificial intelligence, what it's doing is it's a thinking process, and basically it's working somewhat similar to how our mind would work, except it removes the mind. So it works more like a brain and removes the limitations of the human aspect, right? So it's sort of taking like a brain and a computer and putting them together, and that's really cool. So it allows us to be a lot more progressive. It allows us to be much faster. It allows us to take otherwise information that was very challenging to aggregate. And so, what I mean by aggregate, so that if you go for a physical examination with your primary care physician, just a general evaluation, so they take vital signs, heart rate, blood pressure, respirations, temperature, and then they don't tell us specifically what's wrong. And then if we do see something there or someone's complaining of something, we draw blood, and then we look at chemical aspects of what's going on in the blood. And even then, if we see certain levels are off, it doesn't necessarily tell us exactly what it is. And that's been, the progression in healthcare diagnostics itself, was to be able to identify, specific markers on cells or DNA to help identify exactly what a problem is. But that's not how, we grew up, and that's not how we do most general medicine. We have to aggregate that information and then put it all together in our brain as we're looking at it on paper, and sort of saying, oh, yeah, all of those things put together give me the characteristic of XYZ, right? A certain pathological condition. So here's what's interesting about the influence of gait, or locomotion, as we really like to call it, is the influence of so many different pathological conditions influence walking. Something as simple as that. Why is that? Well, if you think about any system that can have a pathological profile to it, therefore, because we bring in so many different systems within walking, it has a really unique aspect to give us what's referred to as a performance-based outcome measure, right? It's sort of the ultimate goal of bringing all these systems together. Historically, it hasn't been able to tell us exactly what's wrong with the person, but at least it tells us, say, hey, something's wrong and we need to go a little bit further. And this goes from, behavior or cognitive aspects. And by the way, there's so much overlap here too, even with low back pain, that studies have identified, one of the reasons that patients have abnormalities with the way that they walk, it's not because they're actually in pain. It's not because they're guarding. It's not because they're afraid of something. It's actually the cognitive change as a result of being in chronic pain. So that's another unique aspect, and I'll cover a little bit about that. But as you can see here, that we're really covering a lot of the gamut, and really I've highlighted some of the biggies, and then of course I like to sort of put the biggies really up front, and low back pain is one of those. Spinal pain or low back pain, or the influence of low back pain and neck pain. There's approximately 1 billion people in the world at any given time, that have that problem. Just in the United States alone, on average, it's been costing us about $134.5 billion a year, which is number one in our healthcare expenditure as a single condition. So that's rather significant. And then if we look at the top five in general, there's about three of them in there that also fit what we do in that conservative physical medicine space. Well, and as you can maybe imagine, that some of these might be preventable based on what we also know about things like mobility, walking, physical activity, and so on. In general, the literature shows us that we see some particular aspects with regards to the condition. Now, we don't always see these in every single person, but we have to be able to tease that out, and that's why we take more than one test typically. But we get a lot of information when I just do one single analysis. So I get to look at their walking velocity. I get to look at their overall profile, which is their step and their stride and the relative percentages. We see changes as a result of center of mass and trunk coordination strategies. We see the influence of that on things like stepping and stride length. We look at variability. As a result of variability, even in the upper extremity, it changes my walking pattern as my feet come in contact with the ground. We also look at that variability in terms of motor control. So motor control is something indicative of something's changing in the body. And what's interesting is you don't have to be in pain. And in fact, just being in pain doesn't necessarily mean that you're going to have the problem. And I use the analogy of, driving in an automobile, because I was half joking with a colleague at an event recently who's from another country, and I said, "What's interesting is, by law, I have to take my car to get inspected every year to make sure that it's safe to drive. In other words, we don't wait till the wheels fall off, or I, run off the road to repair tires or brakes or things like that. But yet, that's our entire healthcare system is essentially management by crisis. There's been so much emphasis on pain across the board in research by healthcare practitioners. We advertise it. It's a reason to come in and see us. It's a reason we do X, Y, Z, and that it's part of the aging process. It's part of the indication that something's actually wrong when it couldn't be further from the truth that we really should not probably wait for that. So I love the study by Albez et al. In 2009 that actually just improving gait patterns can reduce chronic low back pain. The reason that that's such a cool study is the emphasis was not on that locale, not going towards the low back, but looking at functionality and saying, oh, well, you seem to have a short leg on one side or the other. Well, if we correct that, guess what happens? It reduces your low back pain, and the goal was to improve overall functionality or performance. Or you had lower contact time on one side versus the other, and we fixed that with maybe some biofeedback, for example. And guess what happens? Their low back pain goes away. And so that's again what's interesting is using performance-based outcome measures. It's no different. I mean, if you play a sport, ever watched a sport, been involved in sport, performance outcome measures is how fast I can run, right? If I can't run very fast and I'm a baseball player, they're probably not going to send me the signal to try and steal second base, certainly not third base. And so other performance outcome, how far can I kick the ball? How far can I throw the ball? Am I supposed to be able to throw it fast or slow? Those are performance-based outcome measures, and we assess those things in sport, and we use them to inform whatever it is that we're trying to do with these particular patients. So what's interesting is initially, so many athletes will lose time as a result of low back pain. So here's some cool statistics. The number one condition in the world globally. I already said that. It's the number one expenditure cost. It's the number one reason a major athlete's going to miss an event, which is interesting. And so it's quite prevalent, and we should probably do something about it, but not wait till there's some issues. I joke, when I'm from the Boston area, so Red Sox fan, and when Big Papi was in his hitting slump, that I emailed them and I said, I think I can help. He was experiencing low back pain. He wasn't in pain anymore, but he had dysfunctional movement patterns. I mean, think about how much motor control you need to have to be able to hit something that's being thrown at you, over 90 miles per hour. So studies are pretty clear that even when low back pain is gone, there's still abnormalities in motor recruitment patterns and latency patterns and in how the body is actually functioning. One of our most renowned researchers in spine, Stuart McGill, Dr. Stuart McGill from Canada, figured out that, wow, we need to make sure that we look at the criteria for bringing subjects into a research event, because guess what? If they've never been remediated, even though their low back pain is gone, they're not a non-low back problem, right? If they've never been remediated, they still have that problem. So just because pain went away, so it was an interesting way to actually look at how to recruit subjects when it came to human movement studies. So why is human movement necessary? Can't we just look at the low back? Well, not really, because if it's a functionality thing, and those clinicians out there know, probably what I'm talking about, but stereoesthesia, graphesthesia, two-point discrimination, a lot of proprioceptive feedback. It's some of the poorest in the lower back, the lumbar spine. So it's kind of difficult to actually assess, the sensitivity, the fine motor movement that you might have in your fingers. The Shane H effect. So I had an athlete come to me. He was a former college athlete where I was at the time, played football, went on, got drafted, played in the NFL for a few years, and then ended up in the CFL, came back and played indoor. And by the time I saw him, he came to me because he was recommended to me because he was experiencing low back pain. And he was a professional strongman competitor. So I go through my typical evaluation and, couldn't find anything. I said, "Are you in pain right now?" He's like, "Well, no." It's like, it's once I start lifting the 300 pounder, right, to get it up there, which I think is funny because, again, most people don't even have that capacity to begin with. So he doesn't actually experience low back pain until he gets to that level. So what we needed to do was actually figure out, what was going on, and why do we test some really simple things like this. I don't know how well you can see that picture down there, but this guy goes bending over backwards, and it's kind of a motor control thing in that it's a really good idea, that we probably test that. This is another example. So this is one of the ways I used to test. This is a very linear approach. So it was actually using gait analysis. So when I say linear approach and gait analysis, those terms actually make sense because it's like what I also have to do when I draw blood, right? And look at x-rays and MRIs is aggregate that data and make that decision. So this was an athlete with acute low back pain, a university volleyball player, and we're looking at flight times of her step gait and looking pre and post. So you can see the top is pre and then post is going to be on the bottom. Well, why did we do that? Well, because we can actually use movement patterns to collect this data and look at the abnormalities. And one of those statistics is variability. And if you look down below, you can see across the board, and even if you don't know this, but if a normal percentage of variability in these metrics should be about between 2 and 6%, she's at 9.3, 17.4, 9.8, and 10.5. And I know you smart people are going, well, if she's in pain and not moving very well, you probably don't need to test her to know something like that. And you would be 100% correct. So why do we bother doing that? Well, again, this is also about informing the clinical decision-making process, as well as proving to people that it's not just about pain. So I don't normally do pre and post treatment measures because it's kind of like, exercising and expecting a change after one session. In fact, mostly when it comes to exercise, people actually get worse. Not really the case here. So in treatment, we would expect some potential benefits and changes. But as we see in the post treatment, she goes down considerably in all of those metrics and actually goes into normal values in 3 out of the 4, and certainly a very significant change in the one that we did not even get to. So even though she's like, yeah, I feel better, I'm not in pain anymore, I'm like, well, you're still not there yet. You're still lacking something. And that's important to be able to convince people that just because you're not in pain doesn't mean you're functioning optimally. Now, when it comes to the athletic population, that can be pretty simple, right? You're not going to run as fast. You're not going to be as strong. You're not going to be as powerful. And so if I'm the coach, then I need to make a decision. And am I better off putting someone in their place? The other potential problem with that is the risk of re-injury. And that's also something that's hugely important to make sure that we take into consideration. And especially as I told you that, low back pain is the number one. So we get to this, why is this a must-have for low back pain? I skipped over my agenda real quick, and so there's an agenda to this, and I have an agenda, and my agenda is to potentially reduce the number of surgical procedures that occur, the number of body part replacements that occur, because we are spending obscene amounts of money on healthcare globally, not just in the United States, but globally. And we can certainly do better. So low back pain is actually, it's not about pain, it's about functionality. By the time someone is in pain and they go see someone, that's a problem. And in fact, statistics show us that they came to us because they think they're in pain, but they actually came to us because they have a problem with functionality. In other words, when we tease it out and I say, okay, so why are you here? Oh, I've got low back pain. How long have you had that? About 3 years. Well, they came to me because of low back pain. No, they've had it for 3 years. And then they say, well, I can't do XYZ anymore. So they actually came because of the limitation in functionality. So it's about function, and pain is just one of those symptoms. It's not a sign, it's a symptom that says something's wrong. By the time you were feeling pain, You're way beyond just a dysfunctional movement pattern or some other dysfunctional pattern within the system. So the answer is we need to do a better job at focusing on function. I know, at a later date in one of these sessions, we'll talk about return to play criteria. Very popular. Why? Because, ACLs and athletes, and it's like, well, that's great. We have about 175 ACL surgeries per year. And I won't even do the numbers for you, but I already told you that number one is low back pain expenditure. So you want to make a dent in healthcare expenditure, you need to look at those sorts of things and not just popularity. Why is it popular? Well, because even though it may not cost us as much for ACL injuries in direct costs, it actually reduces the revenue that's produced as a result of sports, right? So there's loss prevention here by also making sure that we're taking care of things that otherwise don't seem like they're the top at the expenditure, right? So the focus on function does a few things for us. It helps us realize that we need to make sure that we look at problems not from a pain perspective. We don't wait till the wheels fall off the automobile to do anything about that, but we look at the wear pattern, right? We look at the wear pattern and we make changes way before that. So, how can we do that? Well, we need to do that with data, but we also need to do that easily. And I've worked with multiple organizations, that develop products and they're like, hey, this is a great thing. And it's like, well, that's great, but you have to change a behavior pattern in the clinical care setting, right? So people said to me, "Oh, I've got a great tool, to help you treat low back pain." Like I got all the tools. Treating the pain isn't an issue. Most people will tell you that I can do it really really well. The problem is, once the patients leave and they go back home, the problem is for patients waiting until they're actually in pain. So it needs to be very cost effective and time effective for me to implement that within the clinic, and it needs to check several boxes. One of which is convincing patients that, what, it's also not just about pain, right? So one of the things that we look at is being able to collect, aggregate that data and turn it over rapidly, efficiently. And by efficiently, I mean not just based on the time, but what impact does it have for me as the clinician, for me as the clinic owner, for the patient, for the compliance, for the retention, right? Because people forget all about that. There's a nice statistic, it's not nice, it's a horrible statistic. 30% of outpatient physical therapy patients finish and complete their course of care. 70% is left on the table. So when we look at data associated with surgical procedures and conservative approaches, is it any wonder why sometimes it's a wash and why you would think, well, how can a $50,000 surgical procedure be as cost effective as conservative approaches? It's because we're not doing a good job at creating behavior modifications in the patient population. And part of that is proving to them and showing them information, but specifically showing them information that they can relate to. So what we see here, and these are some of the metrics, and I'll talk a little bit more about this, is addressing those metrics that I showed you earlier, things that change as a result of spinal pain or previous spinal pain that has not been rehabilitated, right? So symmetry, looking at the right and the left. What's interesting about people that have low back pain or had low back pain, they compensate for that. And actually, this is very consistent with most anything that actually occurs. People compensate for that and they take a strategy that otherwise is less painful, and that fixes the problem. It doesn't. It's like, okay, I have a worn out tire and I'm going to take another tire of a different size and put it on there because it's the only one that's available. Eventually, I'm going to have some other problems with that. So we see that symmetry is a really simple, basic characteristic. It doesn't, one, take a rocket scientist to look at, right? And it doesn't take a lot of time. So the artificial intelligence and the machine learning aspect is able to collect this data and actually show us, the highlights of really what's wrong with people. Because as I said earlier, it's got to be time, it's got to be cost effective. I need to be able to read it quickly and aggregate that information. And if artificial intelligence can kick in, that would be awesome. So here's another use case example. And so I'm going back on my word again. I say that I typically do not take pre and post treatment data. But this was frustrating because this patient came in, just turned 50 years old. She's had low back pain for several weeks. She works on a farm. She's also a yoga instructor. So guess why she came in? She could no longer work. She could no longer, teach yoga. And so she's experiencing low back pain. So I do an assessment to actually show her her mobility patterns, right? Her walking patterns. And I purposely make her walk slower than what some people think, because that's like, taking that automobile again and riding it at a really slow rate. That, you know what, if it's not working at that slow pace, guess what it's like when you're trying to get on the highway, right? And that's when you get in danger, if you don't have good brakes and tires and things like that. So I do the pretest, and you can look over here to the left and you can see what we're looking at here. This is something called propulsion rate. This is a ratio between the hip flexors and the plantar flexors as you're going into that swing phase, which is when you're taking your foot off the ground and moving it through space to then put your foot back on the ground again. So that's taking a swing part of your stride. And we can see that she's not really using her hip flexors. And so she's really doing a lot of that work by pushing off with her gastrocsoleus, her calf muscles, which is also a compensatory strategy that we tend to see in the older adult patients. Why? Because they're losing core stability, they're losing strength, force, and power as they're aging if they're not keeping themselves in halfway decent tip top condition. So, guess what? The other reason that she's not going to use her hip flexors is because of the influence it has on the core stability and why she's experiencing pain. In fact, some of these muscles actually get shut down. So she has no choice but to create a compensatory strategy. So I treat her, we get done, and she's like, wow, I feel great. I'm not even in pain anymore. I must be fixed. I'm like, well, if you knew me any better than you think you do, it's not about pain, young lady. And actually, she's 50 years old. So she is a young lady, but she's like, well, what do I got to do for this not to happen again? So I'm like, well, let's just hypothetically take another analysis. So, yeah, as you can imagine, I reduced her pain and she's moving better. Her performance outcomes are a little bit better. But yet, as we can see here, and by the way, most of her pain is on the right side. We've improved this ratio here, but now we're still seeing what we saw, pre-treatment. And I said, one of your problems is you're lacking that core stability. And most of us would say that's probably an issue with a lot of people with low back pain. But I can actually show her and associate it with something very simple as a walking metric. And here's another one. This is specifically looking at her foot patterns. And so we can see that she tends to pronate, especially when she is walking when she's in pain. And again, it's another compensatory strategy, right? And so then I treat her, and guess what? Whoops, I went too fast on that. It actually starts to correct itself. Why is this important? And as we say, and when we look at the sequence of events that we perform in therapy, sequence matters. so so the reason I like to use walking, something really basic, is it addresses all those systems. But when I treat someone, you have to treat them first before you do their problem, before you have them do their exercise therapy, because you don't just want them doing their therapeutic exercise. You want them doing their therapeutic exercise therapeutically, right? So if you were to do it first, and a lot of clinics will do that just based on the way that the people enter the clinic as a patient. Oh, well, this busy over here, so why don't you go do your walking on a treadmill, do your exercises first, and then come over and we'll do your e-stim or whatever the case may be. That's not good, right? Because now you're actually have them doing an exercise, which is what? Yes, it's very repetitive and ingraining, and you do not want them to do that with antalgic position or abnormal movement patterns. It's like taking that car in and identifying the fact that, yep, you've got very worn tires. You know what? We don't have time for you just yet. So go ahead out and keep driving. We don't want to do that. Another really interesting metric is, again, looking at that foot pronation supination. And also in here, we see this variability people that have this acute pain and these changes in strategies, they tend to see a very wide variability. I told you earlier that that is sort of natural in that 2 to 6% difference. When it's too wide, it means they don't really have good motor control. And this makes sense. This is throughout her entire lower extremities. And I also wanted to show her that, I can't fix everything in one treatment. We do some good, but it needs to be structured as such to make sure that, it's not just about pain, it's actually about the functionality. So I was able to prove to her that, just because you're out of pain, if you really don't want this to happen again, you need to keep getting treated. You need to keep doing what's supposed to be doing. I often have people come in on sort of a regular basis, just even to get tested. So the other thing that we're working on more so today than ever is looking at the evolution. So it's between and within. So on the left here is actually a run. So this is a 5-kilometer run. I can look at step-by-step analysis. And then over here on the right is actually looking at that change in that particular metric as a result of all the different tests. And you can see here, each one of these dots is actually a different test. And if you draw a line of what's called best fit, you can see that it's improving, right? And so again, that's a very powerful tool when you're goal setting, but also when you're trying to get your patients to buy into the fact that you're doing them good. It's not just about pain, and that, if you walk less than 2.4 miles per hour, you're at much higher risk of death. And then you can do a death, right? But you can use that information to really make some of those changes with the information that otherwise is very consistent. So, but it's challenging. It's hard because this is a behavior modification, because it's a new technology. But like I said, you need to look at this from the efficiency perspective, from multiple, both the direct and the indirect benefits that it can potentially have. And so a big barrier historically for us has been like insurance reimbursement, right? That's always been an issue for a lot of people. But it's actually more potentially about efficiencies. It's more about doing a better job, which again, all of this really revolves around patients and getting patients in, either from referrals from another practitioner or from referrals from other patients. So we're actually at a place like I can actually collect more data, useful data that informs me in literally like 2 to 3 minutes, that used to take me a $500,000 lab and sitting down and running a lot of statistics. And so one is it's available to us. Two is you don't have to be a lab geek or rat like I used to be, that the information is pretty simple. Symmetry. You don't have to be a clinician to know what that means and to be able to look at a percent and say, oh, well, you're at 90%, that's normal. You're at 75%, that's not normal, right? And then they can take their background and what they've been taught as a clinician to make that change. Adapting versus adopting. What we really need to do is a combination of both of these things in terms of the implementation. We also need to look at and stop treating based on pain, right? Because that has so severe limited capacity to it on both the front and the back end. Locomotion, it doesn't get any easier than that. It takes me about 30 seconds to have somebody walk. The amount of data that I get, how I can look at it and connect it to the assessment, is the rest of the assessment, and the review of findings, how I can actually show people, is pretty awesome. And lastly is just that low back pain is not about pain, right? That's my agenda, and that's my soapbox that hopefully we're going to get to change. So that's my contact info. Again, sincerely apologize for the issues. Hopefully be on the lookout. We've got another one coming up, and so we do want you to come back. We will probably run this again. My information, my email address is c.proulx, and no, it doesn't sound like it reads, but it's PROULX as in xylophone at digitsole.com, DIGITSOLE.com. And
great job, Chris. Great job.
I didn't know if I could do it, Josie, but
you did good, Chris.
That was great.
We're still recording and everyone's on. Is there any question?
Hopefully no one lost any money. So if I know it's the top of the hour, everyone's got to go. But feel free to give us a holler if you have any questions. Happy to communicate those directly. This is going to be available, so you can go back and watch it again if you're having difficulty sleeping and you can't get the melatonin to kick in that night. Or if you want to share with some other folks, we will also eventually upload this to our YouTube channel, and we'll be able to share that link pretty easily as well.
Yeah. Thank you, Chris. Appreciate it. Thanks everyone for joining. Look forward to seeing you again. We'll get the hiccups out of this and be ready to go the next time. So
yeah.
apologies, but thanks again for joining.
All
Have a
right.
great
Thanks,
day.
everyone. Bye-bye.